p.m. So please, if you are going to the airport, the bus will be leaving by 1 p.m. The bus is outside. Dr. AbdulRahman, you have 10 minutes to speak to us.
Okay. Good afternoon, my teachers, my colleagues, ladies and gentlemen. I want to apologize for being unavoidably late. My topic for today is a comparison of one-side and two-side peribulbar anesthesia that was conducted at National Eye Centre. Cataract surgery is the commonest intraocular operation performed in the world, in the world of ophthalmology. And most elective surgeries in adult patients are done under local anesthesia, which has evolved considerably because we have different techniques ranging from retrobulbar to peribulbar at different size to subtenon anesthesia, topical anesthesia. But most of these techniques of giving local anesthesia involve the use of sharp needles. And some complications resulting from these sharp objects can result in sight or life-threatening complications, some of which may require advanced life support. For example, if in the course of injecting the anesthetic, it accidentally goes into the subarachnoid space, it can travel and give up to the brainstem and give and impair consciousness and respiration. But other complications that can be sight-threatening may result in poor outcome that will require additional care, which may or may not be available or affordable, especially in the developing world where we practice. So the aim of this study was to compare the efficacy and safety of a single medial canthus injection with the classic double injection peribulbar anesthesia for cataract surgery in adult subjects at National Eye Centre KADUNA. So it was a prospective randomized controlled double-masked study that was registered with the clinical trials register with the registration number there. That was done between October and December of 2012. And 100 patients with age-related cataracts were allocated to 2 equal groups. And local anesthesia was given using the same mixture of xylocaine with adrenaline and hyaluronidase, using the same size of a needle, the 23G 32 millimeter needle. The blue needle we use that comes with the 2 ml syringe. So the 2 groups, group 1 received a single injection into the inferomedial orbital quadrant. This was group 1. This is the inner canthus and this is the outer canthus. So group 1 received a single injection into the inferomedial orbital quadrant. This was the intervention, while the control group received 2 injections, one in the inferotemporal quadrant and one in the suprarenasal quadrant. This is what we routinely use at National Eye Centre to block our patients for local anesthesia. So then after anesthesia was injected, the patients, we applied ocular compression using a modified pediatric cuff because we did not have the Honan balloon, and pressure was standardized at 30 millimeter of mercury for both groups. And then after 10 minutes, we assessed ocular and lid akinesia using a 3-point scoring system that enabled the subjects to either get a maximum score of 10 or a minimum of 0. And we also scored the patient and the surgeon's satisfaction using another 4-point scoring system. And the primary outcome measures were the time to achieve an akinesia that was adequate for cataract surgery, the number of supplementary injections that needed to be given, and the pain of injection and surgery as reported by the patient. While the secondary outcome measures were the number of injections given, the volume of anesthetic required to achieve akinesia that was adequate for surgery, complications related to local anesthesia, duration of surgery, and the satisfaction of the surgeon with the block. And data was analyzed using SPSS version 16. So we had 100 patients, and the mean age in group 1 was 64.3 and 62.6 in the in group 1 and 2 respectively. We had 29 females, we had 29 males in group 1 and 23 females in group 2. The average weight was 61.4 and 57.3, while 24 right eyes were operated in both groups. So the results showed that the time to achieve adequate akinesia was within the first 10 minutes of giving the block. 41 patients in each group achieved that within 10 minutes, and 9 patients in both groups within 15 minutes. And the need for supplementary injections were equal, while the pain of anesthetic injection, pain of surgery, total number of injections. For the pain of anesthetic injection and pain of surgery, we used the median score. It was not statistically significant between the two. But the total number of injections was significant because group 1 had an average of 1.18 injections, while group 2 had 2.18 with a p-value of 0. Total volume of anesthesia and duration of surgery was almost equal between the two, while the acceptability of the block to the patients was 100%. When we asked the patient, for your next cataract surgery, would you like to have this technique of anesthesia? And irrespective of whether they were in group 1 or 2, all of them said they would want to have the same type of anesthesia, and the surgeon satisfaction score was also the same. So from the results, it shows that the two techniques, there's a similar efficacy between the two of them. And because almost more than 90% of the patients achieved anesthesia within 10 minutes of giving the block, this technique, either 1 or 2 injection, is suitable for surgeons who are very fast. If you can complete a cataract surgery within 10 minutes, then it makes sense to block the patients and line them up. That way there will be no need for top-up injections or having to apply topical anesthetic or reblock the patient on the table. While the equal need for supplementary injections, average pain scores, and the volume of anesthesia was similar for both. The volume of 5 mils we used was among the lowest reported in literature, because some other authors have reported using mils as high as 30 mils of xylocaine in order to achieve successful akinesia. Then the literature reports using...
You have 3 more minutes.
Okay, in the literature, where there are different scoring systems, some 10 visual rating system, some using color coding, but it was cumbersome explaining that. So we just modified a simple one that would enable patients to understand. And none of our patients required topical anesthesia during surgery, maybe because we're Africans, we're used to giving birth without anesthesia, we practice tribal marking or bloodletting. And it was interesting to note that chemosis was the commonest complication that was seen in those who received the 2 injection technique, and then a single case of downward and inward deviation. So theoretically, because you are given one injection in group 1 and 2 injections in group 2, that doubles the risk of anesthetic needle-related complications when you compare the 2 groups. And then the need for multiple injections in group 2 subjects the patients to more pain and takes longer to administer. So in conclusion, the single technique is as good as the double technique in providing adequate conditions for cataract surgery while reducing the risk of needle-related complications. Thank you for your patience.
Thank you, Dr. AbdulRahman.